Don't worry, there's about half an hour for coffee. And have questions, the floor is now open.
I have a
Dr. S.V. Low.
Okay, thank you very much to the three speakers for their very informative presentation. I have a question for Lord Darzi, and wonder if you could share your thoughts on how primary care could ease the burden of hospital systems, particularly during winter surge. I think in Hong Kong or even in the United or globally, when temperature drops, particularly in winter times, the hospital systems is clogged up with patients. I just wonder how primary care can help to prevent the flood of the patients into hospital during winter surge.
Sure. May I just say, I think it needs to be within the context of primary and community services. Primary care on its own is not going to achieve that goal. And you will see this in parts of the country where you do have a well-coordinated primary and community services working in partnership with secondary care. So you really need to take all the boundaries, that this is a partnership between the three. Then the opportunities of ensuring that knowing your population, as I explained, risk stratifying your population, knowing that you've got your flu immunization, you achieved your local target in relation to that, knowing who are on your risk registry in terms of patients with COPD, knowing and working not just across health but also with the local authorities when it comes to bad weather, snow, for example. How do you prevent falls on the street, reducing traumas and fractures? You do see a significant impact, but it's not, there's a perception out there, even by secondary care, that this is something that primary and community services could do. You really need to bring the whole local health economy working with councils and others in having a very clear winter strategy if you're going to really have an impact. It is in the best interest of all to achieve that.
Yes. I'm Dr. I.T. Lau of the Hospital Authority. I've been working in the Hospital Authority for diabetes for more than 20 years. And I'm actually glad to see that the Hong Kong government has done a lot to promote diabetes care in the last few years with the implementation of the RAM system. But then I want to ask Professor Chen a question as to how, the Hong Kong government is going to address the huge number of diabetic patients under the care of the specialist clinic of the Hospital Authority. I think everybody here understands that the healthcare financing system in Hong Kong is such that most patients with chronic disease are actually under the public system. And because of historical reason, a huge number of these patients are actually under the specialist outpatient clinics, where the configuration of care is actually not conducive to providing structured care. And I'm witnessing this gap in the specialist outpatient clinics in the Hospital Authority. So how are we going to address this gap?
Thank you. Thank you for your question. Actually, what you have said is correct, and I noted, from the reports of the Hospital Authority that actually many of the SOPCs, the specialist outpatient clinics, are jammed, and many of the patients that see doctors at the SOPC do not require specialist care necessarily, and some of them require primary care. But because of the pressure, of the Hospital Authority, not only in the waiting time of SOPCs or in, procedures, it also have a long waiting time for the, or a limited quota for the primary care for their GOPCs. So therefore, these patients cannot be downloaded, to the GOPCs because of the lack of quota and also the increasing demand, by the public. So what we have done recently is to use the private-public, programs, the PPP, to basically buy more quotas from the private GPs in order to download many of the patients from the GOPCs so that the SOPC patients can be then referred to the GOPCs. So I think these are quite welcoming by many of the people, both the professionals as well as the people in Hong Kong, as well as the patients of the hospital authority. So I'm sure the hospital authority will continue to evaluate this program and hopefully to expand these programs so that to ease the problem that you have highlighted earlier. Thank you.
Margaret Tay from Hospital Authority. I really appreciate the thoughts on the integration between the different sectors by Dr. Donnelly, and I agree with what you've said about the need for integration across the different sectors. But I just wonder, what are your thoughts on actually integrating the allied health services in the private sector with the private primary care practitioners, so then they can form sort of a, consortiums and work on packages that can offer the private primary care patients to have better access to allied health services. I think that will preserve the present system of a dual track system of a private as well as a public system, because if you divert all to the public primary care sector for allied health service, the system will be quite unsustainable. So I'm just wondering whether your thoughts on revamping the sort of the private sector in terms of integrating the two, allied health as well as the primary care doctors. Thank you.
As I mentioned, there are a few things. First of all, it's a change in value system. First of all, for patients to appreciate the importance of these supportive services and that they are of value, all right? So it's not something that comes by free, provided by the public. This is number one. Secondly, it will be the funding mechanism, whether we can have health vouchers to support, because in the private sector, ancillary services are expensive. First of all, patients need to appreciate that they are value, and secondly, somehow there needs to be a financial model to support it, otherwise they're not willing. Thirdly, would be to utilize public ancillary services, and that is where the community health centers can come into play, that you have these supporting private doctors who are working in public-private programs with the hospital authority, and they will get fast-track referrals to ancillary services, referral back, and also their patients can enjoy ancillary services at a much lower cost. So I think this would be the way forward in better public-private cooperation, so that you can incorporate all these very important supportive services which are very well sought after.
Any other questions? Yes.
Hi, I'm Bettina Wan. I also work for the Hospital Authority. My question is for the panel, and perhaps with Lord Darzi commenting on the Hong Kong situation. I do believe that integrated care model is best for patients with chronic diseases and also for the elderly. And it doesn't just involve getting a whole bunch of people working together. And integrating to meet the needs of patients does mean breaking down professional barriers, restructuring, which can be quite threatening. My understanding from studies looking at accountable organizations in the US and also integrated care models in the UK is that for these models to work, you need leadership, collaboration, you need to have a clear idea of what you're trying to achieve, but more importantly, things like accountability and performance-based measures as well. And I know it is important to engage stakeholders, but I think in the last presentation, the speaker mentioned that one of the things that we need to do is to ask the private sector what they want. If I were a private practitioner, I would probably say, I quite like practicing without having to complete family medicine training. I would like to continue charging fee for service and work as a solo practitioner. So if you do believe that integration is the way forward, how committed are the academies and also the Hong Kong government in imposing the necessary regulations and framework to support that?
Perhaps Donald first and then Sophia.
In a way, right now, health voucher systems and support, from financial support, there's a certain degree of auditing in a sense, because you have to hand in your chips, your slips and all that. There are protocols you're supposed to follow. So I think incentives ultimately is very important, and also, I wouldn't say regulation, but some kind of auditing role on taking an account of what has happened, outcomes. Very simple, diabetes, you can look at simple things as achieving A1C levels and all that in a report system. The Hong Kong College of Family Physicians has this kind of voluntary auditing system, which I think would be helpful. Everything can start by voluntary, and also getting some kind of certification of quality, of management, of certain chronic disease. All these would be a start. But I think ultimately, if you're having additional funding, then you can put requirements on participation in the program, and in that way, you can sort of not regulate, but at least have the practitioners follow certain protocols that you would like.
Thank you. Thank you for your question. I can't agree more with Donald's note on incentives. We have lots of capacity in the private sector, and the private GPs told us that. So they are very happy to work on programs or PPP programs that we can, first of all, through these programs, hopefully, as Donald said, change the mindset and get the public and the private people to work together, first of all. Secondly, how to incentivize the private GPs to work on this. I mean, it is not without problems and not without challenges. In fact, if you ask, people in a hospital authority who are working on this, even with the fees and charges and the level of charges, there are lots of arguments and also, issues. However, I think, there is, I heard some GPs, told me that, other than the incentives or financial incentives, there are other incentives that they can, first of all, help the hospital authority in terms of downloading some of the patients and moving them to the private sector. So in theory, that can give them some business. The other thing is, is really to help, the entire profession. For example, in some of our cataract surgeries programs, is really to help the younger generation, the younger professionals, to, get more practice, in participating. So I think, we'll continue to work on this, and hopefully that with the more evaluation, we can tell us the best way forward and how to work better in our programs.
Comment, all right?
Yeah, I'll make a couple of comments. The first comment is I wouldn't really bother asking the physicians in the private sector. I'll start with the patients and what the public and the patients want. That's what matters. I think secondly, I couldn't agree more. This idea that the public sector will take over the private sector is structural, that doesn't work. Maybe I forgot to mention that most of primary care in the UK, actually, the practices are owned by the physicians. They are private practitioners. But what they have is a contract with the government that is acting on behalf of the patients. And that's really what the issue is. So I don't think this idea that even the Soviet Union have given up the fact of nationalizing the private sector, so that's not the business you should be in. There's an issue about, you need to triangulate price, cost, and value. That is very extremely important, because some of the figures you shared were so, you don't know where you stand, whether it's the private sector charging this, the public sector. I'm sure the figure is in between, something in there. There is a cost to what people do. I think it's important to really look at what is the value generated out of that cost, We know what that is usually in the public sector because we have a very transparent system. You do know when you have a hip replacement, what is the value generated out of that. It's very difficult to measure that in other sectors. And there's obviously a price because ultimately the private sector is there to make a profit margin. So I think there is a lot of incentives in there. So I don't believe in structural change, I believe in transformational change, and I think there are wonderful opportunities, as you have done, in public-private partnerships, which is more or less what we've done in the UK in many instances to deal with some of the major challenges. 10 years ago, the biggest private-public partnership was to deal with the burden of elective care and patients waiting on waiting lists for about 18 months. And that public-private partnership led to a significant impact on the cost and the price because the private sector had something called spot pricing, which is about 3-4 times of what the private sector was charging to the insured population. So coming up with reasonable deals in between. I think ultimately you have a fantastic health system and you're trying to struggle and thinking where to take it to. The opportunities are always there to improve and reform any system.
Are there any further questions or comments on primary care? Well, if not, it remains for me on your behalf to thank our three very distinguished speakers and for their thought-provoking talks. I think we all need a caffeine boost. Please be back in whichever room you wish to be in 20 minutes. Thank you.